Hello, everybody. This is cardiovascular disease part 3. Okay, let's talk about diet for cardiac rehab programs. The typical American diet and then the reversal diet, this right here is what Dean Ornish does. And keep in mind, it's called reversal diet because it actually pulls the fat out of the arteries all over the body, including the coronary arteries. It pulls out the triglycerides, it pulls out the bad cholesterol. And so it actually reverses the plaque buildup. So it's removing the plaque. The typical American diet, 40 to 50% mostly saturated fat. Dean Ornish gets his patients down to 10% fat. And to go that low in dietary fat, you have to go vegetarian and get rid of meat. Or if not a little further, go vegan and get rid of all animal products. So vegan would be no dairy, no cheese. That would be painful for me. But vegetarian would be just no chicken, no meat. A lot of diets will allow for seafood. The typical American diet in terms of carbohydrates is 20 to 35%, and carbs kind of get a bad reputation in the US, but it's simple carbs that people need to cut back on, not complex carbs. And so in the Ornish diet, it's 70 to 75% carbs, but that's coming from brown rice, it's coming from pasta, it's coming from legumes and beans, it's coming from vegetables, and coming from fruit, as an example. The typical American diet is 25% protein, and Ornish gets them a little lower, 15 to 20% protein. And then the typical American diet, this is really what's driving cardiovascular disease, is 400 to 500 milligrams of cholesterol the typical American is consuming. Ornish gets them down to 5 milligrams of cholesterol. And again, you get rid of those animal products because we as human beings, we all make our own cholesterol, and it's necessary to have cholesterol in our bodies because it keeps fluid in cell membranes. You know how fat and fluid don't mix. It keeps our cells fluid in the cells where it's supposed to be so that, we're not leaking all over the place. And then cholesterol is necessary for making of sex hormones, as an example also. All mammals make their own cholesterol. We do not need to consume cholesterol from other mammals to have the necessary amount of cholesterol that our body needs to function. And so if we stop consuming mammals, then we stop consuming extra cholesterol. And that's why Dean Ornish's reversal diet is vegetarian, if not full-blown vegan. This is research on people in the United Kingdom, so over in England. And at the time they did the study, they found that 14% of people in the UK get regular exercise. So a lot of people are not exercising on a regular basis. And in 2010, the average Brit was taking 17 medications, and it was only 11 in 2000. So there's a lot more reliance. Same things happened here in the United States as happened in the UK. We're relying more and more on medications also. But in the meta-analysis, and again, meta-analysis is a study of studies. So taking all the studies out there that have compared medication use with lifestyle use, they have found that exercise is better than using drugs for stroke. The diuretics are better than other drugs and exercise for congestive heart failure, but that's at the end of heart disease when the heart is getting congested and it's not pumping, so the whole body's swelling because the heart is congested and dying. And then they found that exercise was equivalent to drugs for coronary heart disease and diabetes. And so what this is just saying, when we sort of pit lifestyle with medications, secondary prevention, so using lifestyle to prevent or after cardiovascular disease has developed, it works. We should be relying more on lifestyle behavior. The lifestyle changes that we're usually asking for in either preventative rehab, cardiac rehab, or true cardiac rehab after the fact. Nutrition, getting people's fat and their calories down to 30%, but keep in mind Dean Ornish gets it down to 10%. And I want you to think about this. If you're not consuming dietary fat, not only does your body start burning your stored body fat, like in your hips and your thighs or your stomach area. I know it's not really your stomach, your abdomen area. It's going to burn that stored fat, but it's also pulling internal fat. It's pulling fat out of the arteries. It's pulling out the most dangerous fat is visceral fat. It's the fat that we store inside our abdomen. So not like mushroom top kind of fat, but inside, more like beer gut fat, if that helps you relate. It pulls that visceral fat. It starts burning our own body fat for energy. And that's where the heart disease really reverses. Most programs include a stress management component like CBT. Most components have a weight management component or diabetes management component. So really taking care of the whole mind and body. I love these programs. Couples therapies. I've worked with couples before where one person has had a heart attack, and it's oftentimes will scare the romantic partner. They're afraid that if they resume sexual activity, like they're going to kill their significant other, they're going to die in the act kind of thing, which happens sometimes. So couples oftentimes need support in a cardiac rehab program, and the local cardiac rehab program invites partners. You're able to, as the patient, bring your partner into the program. Partners allowed to exercise, attend the nutrition classes, all that kind of stuff. That's especially going to be important if it's a partner that does the grocery shopping and the food prep and the cooking. If the diet needs to change, the person who feeds needs to be able to change. There's oftentimes a lot of financial concerns because it's very expensive to be sick, and particularly to have surgeries, and then concerns about their exertion. The treadmill study I want to tell you about had 3 groups, and the outcome variable, the dependent variable, was how soon after joining a cardiac rehab program did couples report that they were able to resume their normal sexual activity. And again, a lot of times partners are very worried about that. They're afraid they're going to kill their significant other. So in one group, they got nothing. That was a control group. In the other group, this was a study where you had men who'd had the heart attack, and they had women as their partners. In group 2, the man got on the treadmill, and they moved the treadmill up an exertion, very much like a stress test, where he had to hold on. And the woman just watched him do that intensive walking. In the third group, the man got on the treadmill, they increased the exertion until he had to grab on, and then he does that for a little bit, and then he gets off the treadmill. Then they invite the female partner to get on the treadmill and move to that level of exertion until she had to grab on. And so obviously it was group 3 resumed sexual activity sooner. Group 2 resumed sexual activity sooner than the pure control group. And it's one of those things, I mean, I think we can relate to this. She got on the treadmill and she gets up to that level of intensity, and it's like, oh, if he can do this, he can do that. And they're able to resume normal sexual activity, which is a good healthy thing for couples. We've already talked about the prevention, the nurses' health exam study earlier in the semester, but I want to talk about it again. We know that the women nurses in that study who didn't smoke, exercise at least half an hour a day, had a normal, healthy body weight, were not overweight or obese. They ate healthfully. EDOH is alcohol. If they consumed alcohol, they consumed it in moderation. They decreased their risk of coronary heart disease, which used to be #1 cause of death in women before coronavirus, by 82%. That is huge. And so it's the nurses' health exam study has shown if women lead a healthy lifestyle, it's a dramatic increase in their risk for coronary heart disease. But remember, the punchline was prevention works, but only 1% of nurses were engaging in that total healthy lifestyle. So again, a push, if we could get all healthcare professionals healthier, then that's going to trickle down into their patients. Cardiovascular disease is a progressive disease. It progresses sooner in boys and men than it does in girls and women. But this is a study, it was called the McGill autopsy study, where they took young men who had died, mainly they had died in motor vehicle accidents, and they got permission to perform autopsies to take a look at their coronary arteries. And what they found was 2% of the young men ages 15 to 19 already had partial blockages. That rose to 20% in these young men who had died, who were ages 20 to 34, already had partial blockages. So it is a progressive disease. It is happening. It's accumulation of a disease process that is happening over time as individuals age. I want to talk about the ASU blood pressure study. I was a part of a thesis committee where they were looking at blood pressure in young men in exercise science who came into the labs over there who were college students at ASU. And they were looking at their blood pressure. They were also administering alcohol and looking at their blood pressure response to alcohol. But the thing that surprised us the most was how many of the young men at ASU, who you would think would be young and totally healthy, were pre-hypertensive or were hypertensive. It was kind of scary. So it's already happening, something for you guys in this class to be aware of and to be careful about. Other components of prevention from a behavioral standpoint, certainly getting people exercising, eating that low fat, high carb, high nutrition diet, stress management. If drinking alcohol, drink so in moderation. Heavy alcohol use drives high blood pressure and drives cardiovascular disease. Zero alcohol use is actually a little riskier than moderate alcohol use. Moderate alcohol use seems to be protective against cardiovascular disease. That's usually defined as a drink a day for a woman, up to 2 drinks a day for a man. And then caffeine, we've talked about before, working on caffeine consumption and moderating that. Physiologically, cholesterol, we want the LDL, the bad cholesterol, to be below 130, total below 200, and we want that ratio of LDL to HDL to be below 4. Blood pressure, we've talked about, American Heart Association guidelines, and then we want blood glucose levels to be normal and not pre-diabetic or diabetic. There's a thing called health risk appraisal. You all can, if you want to Google this and do your own health risk appraisal online, you can oftentimes find them. This is where doctors and nurses will use both your reported lifestyle behavior or lack thereof, as well as physiological data like your blood pressure, your heart rate, your cholesterol levels, your glucose level, all that kind of stuff, and enter this personal behavioral and physiological data into a database. And then this is where it takes the epidemiological, the population-based data, and it finds you. Like it finds the people who are like you with the lifestyle behavior and the physiological data. It pulls that epidemiological data down and puts it into individual information. And the individual information is oftentimes relayed to the patient by the doctor in a way that that person can psychologically understand. So an example would be health age. So let's say you are a 50-year-old man, your doctor has recommended you do a stress test and a cardiac workup, and you do a health risk appraisal. That 50-year-old man, let's say that comes back, and the doctor has to sit that person down and say, you're 50 years old, but your body is the age of a 70-year-old. And that discrepancy, that you're 50 but your body's 70, oftentimes is used as motivation. Would you like to hear about how we can help you with lifestyle change to help you bring your health age closer to age 50? So an example might be referring them to a preventative cardiac rehab program. And then they're oftentimes given, if you quit smoking, if you do this, if you do that, then that creates an attainable health age. It's also used in the reverse. Let's say you're a 50-year-old woman and you follow all the healthy lifestyle stuff. And my nurse practitioner does this for me on my yearly checkup type thing. Let's say 50-year-old woman, and you get your data back and it says you've got the physical health of a 40-year-old woman. Woo, it's like motivational too. Keep doing what you're doing. So it's a great way, a health risk appraisal is a great way of giving personalized information to try to motivate patients. It's going to be better if the counseling for the lifestyle change is continuous, as opposed to just one time you're given your health age and you're told, like, go out there and get healthier. The continuous counseling is going to work out better. And then giving people the behavior change strategies that they would need. So health risk appraisal is best if it's used in motivational interviewing. Got it? Motivational interviewing, stages of change, and then moving people in those different health behaviors towards the actual behavior change. Type A personality, this was developed by 2 cardiologists, Friedman and Rosenman. And many of you have heard of type A, this idea that these people are competitive, they're achievement striving, got a lot of time urgency, so I got a lot of stuff to do, they're impatient and hostile and aggressive. Friedman and Rosenman were cardiologists, and they mainly were seeing older white men who had heart attacks in their cardiology practice. And they had been noticing certain types of personality characteristics in their patients. But it wasn't until their office manager came to them and said, the couches in the waiting room are looking kind of ratty. Do I have your permission to bring in an upholsterer, a person to come in and change out the cushions and reupholster the couches? And they were like, yeah, sure. Okay. Yeah, we hadn't seen the waiting room in a while. Yeah, the couches look bad. Let's bring somebody in. And the most interesting thing about the upholsterer came in and said, your couches are worn out in a weird way. Let me see if I can back up my chair and I can kind of demonstrate this. Normally, when people sit on a couch, let's see if this works. Normally, they're sitting back in the back and they're wearing out the couch in the back. But in Friedman and Rosenman's, they were all worn out. The cushions and the upholstery were all worn out on the front of the couch, not the back of the couch. So that's normal. So you've got these dudes in the waiting room and they're sitting on the edge of the couch and they're looking at their watch and they've got all this stuff. They're like, I need to get back to work. And they're impatient and they're not sitting back and actually relaxing in the chair. Okay. And it wasn't until the upholstery person was like, your couches are worn out weird, that Friedman and Rosenman started talking with each other. And they're like, I'm seeing a lot of these dudes, these old dudes come in, and they seem to have these personality characteristics. And that's where the term type A was born. So researchers started studying this. And I can tell you in the older study, the Western Collaborative Group, they looked at these middle-aged men, and they found that if they were type A versus if they were type B is more the chilled person. The type A is the, uptight person, was twice the risk for cardiovascular disease. So in the initial research that they did, type A showed up as being something of a risk factor. In another study, the Framingham Heart Study, they found similar results in men, but it was only in white collar workers. So professional men, they weren't finding this in blue collar workers. And then later research, this effect, this type A effect kind of washed out. So let's talk about why. In the earlier research, they were using paper and pencil survey that's called the Jenkins Activity Survey. And then there was a test, the Matthews Use test, that you use to diagnose type A or type B in teens. And I want us to think about this. So let's say that you've got all the type A qualities and you're doing a paper and pencil survey. So here you are, you're taking your Jenkins Activity Survey, and you would be going like, are you higher achieving than most people? Oh yeah, I achieve a lot. I get a lot of work done. Do you get hostile more than most? Oh no, I don't have a problem with my temper. There's going to be a lot of when you're doing paper and pencil tests, there's going to be a lot of self-serving biases of like, well, great, look at all these wonderful things that I do, but kind of a blind eye to some of your flaws. The best way of diagnosing type A is not to have people self-report their personality characteristics or their tendencies. It is to put them in a situation that would draw out type A behavior. And so they've developed a structured interview. Let's talk about how they do this interview, where you have a trained research assistant do the interview with the participant or the patient. And in the interview, you follow a protocol. The research assistant, and then you videotape it. Sorry, you videotape that interview, and then you have blind raters watch the behavior of the participant or the patient, code their behavior in the interview, and that is what makes the diagnosis of type A or type B. So the research assistant who's doing the interview remains coldly professional. So it'd be like, Mr. Smith, come in, have a seat, let's get going. They, when the person is talking, the patient is talking, the RA research assistant will interrupt them, which is kind of rude. There's a point where the research assistant will stutter, will have a hard time finding words. And what happens if you're impatient and you're type A, once a person's stuttering, the patient fills in the words for them. It's sort of like, let's move this along. If you can't find the words, I'll find the words for you. They challenge their responses. They demean their achievement. So they're in one question, they'll ask them like, what's the best success you've ever had? And the person like tells this thing, they're all proud about my success. And they demean it. They're like, that's it? Like that's what you're proud about? Isn't that me? They will also ask them about something really stressful that happened to them. And the research assistant will take this really stressful situation and try to twist it a bit and make it seem like it was their fault, like they brought that bad thing on. And so again, the diagnoses of type A or type B are made where you have the blind research assistants watch the patient in the interview. And again, if that person is type A, that situation can bring it out, as an example. Later on in the research on the type A construct has found, however, it's really the hostility, the anger, and the cynicism that is the toxic component. It's not the achievement striving. Like when we bring our graduate students into our doc program, we want them to be achievement striving. We want them to be highly productive. We want them to be very conscientious. We want them to be able to multitask, all of that kind of stuff, because that's going to create for success in their doctoral program. In this particular study, I'll try to break this down for you. So they've pre-tested participants, and they've categorized them as type A or type B. And they put them in a room with what they think is just another participant in a study. So they are thinking they're just two participants in the study. But really the other participant is a trained Confederate who is either trained to really cooperate with the participant or to interfere with cooperation. And what they have to do is solve these puzzles together. So again, it gives them the opportunity of the Confederate to cooperate or the Confederate to not be very cooperative and instigate. After they work on the puzzle, they're told they go to separate rooms, and they're still trying to learn tasks. But the participant is now told that they are allowed to administer shocks to the other person in the other room when the other person doesn't get something right. So if they get something right, that's good. But when the other person makes a mistake or gets something wrong, they think they can shock them. No, they're not. They're not hooked up to actually shock them. But basically, in this 2x2 study, type A, type B, and you've got the Confederates either cooperating or the Confederate is instigating and not cooperating, the participants administered more ostensible shocks. They punished their partner more if they were type A versus type B, and if their partner did not cooperate. So if you're type A and you're interacting with somebody who is not helping you meet your type A goals, and in fact that person is interfering with you meeting your type A goals, then you're more likely to want to be aggressive, be hostile, and punish that person. So think about it as, if you're type B and you're driving and somebody cuts you off, you might be like, oh, jerk. But if you're type A and somebody cuts you off in traffic, it might be like, yeah, you asshole, that kind of thing. Okay, so if in the right situation, meaning type A and the hostility of type A is situational, and when it comes out interpersonally when goals get thwarted. So it's not the type A construct, it is the anger, cynicism, and mistrust, and we've got scales that measure that. This stuff more cleanly predicts cardiovascular disease progression. Fraser Smith and colleagues, they have done some really interesting research where they have looked at the psychological components of people after a heart attack. And they have found that both depression and anxiety, so diagnosis of depression or anxiety disorder, increases risk of cardiovascular disease and another heart attack after a heart attack, totally independent from physiological risk. So you measure all the physiological stuff like blood pressure, cholesterol. Just knowing that a person has an anxiety disorder, severely anxious and stressed, or has depression is an independent predictor of another heart attack. And it's this type of data, which is why all cardiac rehab programs, for their accreditation, they have to have mental health professional, at least one mental health professional on staff, doing screenings, testing, and doing clinical interviews for all the patients when they come into the program to screen for psychological disorders. We also screen for substance abuse, as an example, and eating disorders or binge eating, that kind of stuff. And then offering up, if this person flags for psychological diagnosis, offering up treatment for them. Remember that the Dean Ornish program, he has support groups. There's stress management support groups. So everybody, regardless of if they have a psychological disorder or not, are participating in stress management groups, but then also offering up treatment for people with psychological disorders. We know that the relative risk of another heart attack in a depressed person compared to non-depressed cardiac patients is 4 times the risk. So very strong. These psychological disorders are very strong predictors of problems for people in cardiac rehab programs. So I love the fact that cardiac rehab is total mind body, okay? Because they're really getting at psychological risks, they're really getting at behavioral risks. But I want to talk about cytokines and inflammation. We have talked a little bit about the fact that there are neuroscientists now that are thinking that every psychological disorder is really an inflammatory process in the brain. And medical doctors and scientists have come around and realized that so many diseases, not only chronic fatigue and depression and chronic pain, but even cardiovascular disease, even cancer, is driven by chronic inflammation inside the body. So chronic inflammation physically is bad for medical disease, but it is psychologically bad for our brains. And I'll tell you a story here in a bit. And we know that when people have psychological disorders and they have this chronic inflammation, they're a lot less likely to comply and do the behavior change in a cardiac rehab program. But we also know that getting people in the behavior change, getting them exercising, getting them eating more healthfully is going to decrease that chronic inflammation in the body. So I want to talk about the athletes overtraining. And you exercise science folks are going to dig this. So years ago, I was working with an exercise science professor who was very interested in the cytokine hypothesis for overtraining. So I want us to think about athletes and training. So let's say you are trying to run a marathon and you're running your 3 miles and then you take a day of rest and then you're able to run 4 miles, take a day of rest, 5, 10, 50 miles. Got it? Okay. So you train higher and you give yourself the rest period to adapt, because really the improvement in the training effect is happening in the rest. So the training actually creates some damage, and then you've got to recover and rest, and then you train higher and then you rest and you recover and you keep going. So where serious athletes get into trouble with the coaching style or the actual athlete is where they overtrain. And the overtrain would be they've pushed it way too hard that their body cannot adapt. They cannot reach that level of new strength of running faster, stronger, whatever it is. And then they overtrain and then they tank. And as they tank, they lose all their performance value from the previous training. And a lot of times after this overtraining, athletes can't recuperate. So for some athletes, coaches have gotten better at this, understanding the exercise science. But for some athletes, pushing, if they weren't, just flat out injured their body, it's more they've internal injured their body, and then they tank and they've lost their season. Like they can't perform, they can't. So it's a huge risk factor for athletes. But we got in there and we interviewed these cyclists who had overtrained. They had been pushing it with their training group or their team or whatnot, and they overtrained, and we got in there and interviewed them. And it was fascinating to me where we would hear them say, I was, doing hundreds of miles a week, and now I go out and I spin in my driveway, and I just don't want to be sitting on the bike, and I just don't want to spin, and I don't want to have to put in the miles, and I'm sleeping all the time, and I've lost my appetite. I was training and eating really well when I was doing that high mileage. I just don't feel like eating, and I'm oversleeping, and I'm crying sometimes, and I don't want to have sex with my partner. What does that look like from a psychologist's standpoint of view? Depression. It's depression. But this has given me a really interesting, different way of thinking about depression and treating depression in my patients, as an example. And so the cytokines are these pro-inflammatory immune system chemicals that communicate and create an immune system response and create inflammation that is meant to be short-term only. It is meant to find the disease. Like, let's say you have a bacteria that has entered your body. It's meant to find the bacteria, get that bacteria out of the body, and then that person it's meant to be short-term and is meant to create healing. And we're learning with coronavirus, what's really sad is that it seems like some people are getting such a cytokine response that they're calling it cytokine toxicity or cytokine poisoning. And it's what seems to be, and again, medical advances could have happened since I recorded this, it seems to be the cytokine poisoning or toxicity that's actually killing people. So the cytokine response is meant to be short-term. But for some reason, in these athletes who overtrain, and for some reason in people who develop depression, chronic fatigue, chronic pain. If you remember the young blonde ponytailed woman in the New Medicine documentary, the one who was the softball player and the soccer player, she had some kind of a flu. And then after her flu went away, she developed depression, chronic pain, chronic fatigue. Her cytokines were probably through the roof. So the cytokine effect creates what we call sick behavior. And sick behavior would be, I just want to sleep. I don't want to eat. Digestion takes energy. I just want my body's trying to heal. I don't want to have sex. I don't have energy for that. I just want to sleep and not eat and just try to heal. So we go into sick behavior when we have these infections. But what I found fascinating is the depression components. Okay, so I want to tell you about what happened to me. So you see my sunroom, you see the ceiling of the sunroom. So I'd had sinus infections and I'd had bronchitis in my past, and I would wait a little bit when I'd be sick before I'd go to a doctor and ask for an antibiotic, which in hindsight, usually I'd go get my antibiotic. I started taking my antibiotic and it would usually work very well and cure the sinus infection or the bronchitis. So one winter I had bronchitis and I let it go. And I didn't go to the doctor soon enough. And by the time I get to the doctor, and I get asthma that kicks in when I get a respiratory infection, by the time I get to the doctor, I've got pneumonia and my asthma's kicked in and I'm in rough shape. I am in really rough shape. And the first antibiotic didn't work. They had to use a different one to help me with the pneumonia. But I'm out here in my sunroom and it's a cold winter day and I'm warm enough in here. And it's raining and I'm watching the raindrops just roll down the ceiling, which is actually really cool. And it's really cool when the snow rolls down the ceiling too. It's sloped in here. And I'm laying there and I've got a fever and I can't stop shaking and writhing and I can't stop crying. And I'm watching the raindrops roll down the roof and it's just like, the world is so sad. I just couldn't stop crying. I couldn't stop writhing. I would go in and out of that fever state, that kind of delirium type of state. And I was just severely depressed. And it wasn't until I healed up, and that's like not how I roll usually. It wasn't until I healed up, it was like, dang, that was cytokine toxicity. Like I was like really depressed because I was that sick at that point in time. So what it has taught me when I'm thinking about treating depression for individuals is what a lot of individuals do is they're pushing it in life. They're not engaging in self-care. They're pushing it. And they are not feeling good. They get a anhedonia and they keep pushing it. And then at some point, their brain, their mind takes them down. Sick behavior is your brain being like, take a freaking time out. You keep pushing it. You keep doing. You're not taking care of yourself. I'm going to put you in bed. You're not going to want to get out of bed. You're not going to want to eat. You're not going to want to have sex. You can't enjoy anything. I'm going to make you sick and make you rest and make you take a time out. So with my clients, what I oftentimes will do ever since then in all of this information is help people realize, of course, you want to help treat the depression, and there's all kinds of stuff we do, cognitive restructuring, behavioral activation, that kind of thing. We want to bring them out of the depression, but what if the mental illness is a message? What if the message is you can't keep doing it like this? You can't keep pushing it and taking care of everybody else and working all those hours and doing for others and not taking care of yourself. It is usually a very valuable message, but you got to figure out what the message is and you've got to listen to it. And so what I love about knowing about the cytokines, it is the mind-body connection right here. Okay. But I have used this when I've got patients who are really struggling with anxiety disorders, really struggling with depression. I have them get to their medical doctor, do blood work, look for inflammatory markers in the blood. For a lot of individuals, exercise, healthy eating, vitamin D, and some individuals even are so far along they need a steroid to kind of turn off the immune system response. And I know doctors are kind of dealing with that. They don't want to put these COVID patients on steroids and shut down their immune system when they need their immune system to be operating to help fight infection. But for some individuals, that cytokine poisoning, it's going way too far. So I'm sure there are a lot of scientists and medical doctors kind of wrestling with how long do we let it go without a steroid, and at what point do we need to try to curtail that cytokine response. All right, everybody. This is the end of part 3 of our cardiovascular disease lecture. As always, Flipgrid or join the discussion if you've got questions for me, or email me, or we can set up a Zoom appointment.